Good afternoon, and welcome to Healthcare Disparities, Using Data to Identify and Act. This webinar is sponsored by the Minnesota Department of Health and hosted by the Healthcare Homes Initiative in partnership with Stratus Health. My name is Carol Bauer. By the end of our webinar today, participants will be able to explain how race, ethnicity, and language data can reveal disparities in patient health status and care delivery, identify methods to review patient population data, and lastly, suggest interventions to address health disparities. I'll introduce our presenters in a minute, but first, let's review a few housekeeping items. To prevent feedback and sound problems, please put your phones on mute by pressing *6. Please don't put your phones on hold, as that can cause feedback issues. We invite your questions through the chat function, and we'll address as many as we can during the last 10 minutes of the webinar. Now I'd like to introduce our speakers. Laura Grandgard-Johnson is a Senior Research Analyst with Stratus Health. She provides analytic and program support for a wide range of state, regional, and national projects that address quality of care in healthcare and community settings. Her work includes data analysis, reporting, data quality and management, tool and resource creation, and evaluation. Laura has a Master of Public Health degree in epidemiology from the University of Minnesota and undergraduate degrees in biology and religion from Luther College. Chris Singer is Chief Operating Officer at Westside Community Health Services, the largest community clinic organization in Minnesota with 16 metro area locations. As a federally qualified health center, Westside provides accessible primary care to diverse communities with a progressive care model emphasizing education, prevention, care coordination, and integrated services using team-based, bilingual, bicultural expertise. Chris has over 20 years of experience in clinical care leadership in a variety of healthcare settings. She's a registered nurse and holds an MA in nursing from Bethel University with certifications in healthcare quality and leadership. Lastly, Kathy Culhane-Para is Medical Director of Quality at Westside Community Health Services in St. Paul, Minnesota. She's a family physician who received her MD degree from Michigan State University and completed her family medicine residency at the University of Minnesota. She is also a medical anthropologist with a master's degree in anthropology from the University of Minnesota. She's intrigued with collecting data to identify health disparities in order to tailor clinical approaches to achieve health equity. At this point, I'd like to pass the presentation over to Laura.
Thanks, Carol, and I'm just going to spend the first 5 minutes or so setting the stage for Kathy and Chris to spend the bulk of the time talking about the work Westside has been doing. So the fact that Minnesota in aggregate performs really well in many healthcare areas is quite familiar to many people, and so is the fact that we have some huge inequities here. So to set the context, I just wanted to share one example of health and healthcare disparities, in this case specifically by race and ethnicity. So this example here comes from SHADEC's State Health Compare, and this measure shown compares Minnesota to the U.S., and it shows the average number of years of potential life lost before turning 75, essentially measuring early death. And the key is that a lower number is better. So Minnesota here looks better than the U.S. at about 5,000 years lost per 100,000 people. So we're doing pretty well overall. This next slide is slightly older data, but it's the same measure and the same intent, and it's just for Minnesota, but broken out by race and ethnicity. And you'll see a sobering difference compared to the previous slide. So the average number of potential years lost ranges from about 3,500 for Hispanic Latinos at the top of the chart to almost 16,000 years for American Indians and Alaska Natives towards the bottom. And even this likely masks more variation. So as one example, assuming you had access to even more granular data, if you were to disaggregate that Asian Pacific Islander data into even more communities, you'd include people who are Indian, Burmese, Hmong, Chinese, Japanese, Vietnamese, and many more, and you may find even more variation than this shows. So to reiterate, that was just one example, but the bottom line is that often in Minnesota we look great when you aggregate, but digging in and disaggregating the data can reveal huge areas for improvement. One of the key steps to that digging in is identifying that data, and even though it's not all that matters, everything you saw earlier required collection, analysis, and use of data. And part of that requires doing what you can to make sure that the data is accurate, noting limitations if it isn't. I'm going to focus the rest of this intro just briefly describing what that data could or should entail. So first, just taking one more step back with respect to data, why would you want to collect and use it? We already made the case for the biggest piece, which is to move the needle towards improving health inequities. You need data to identify and explore what those inequities are for your own organizations and the populations you serve. Without that data, you may likely have a sense of what they are, but that data gives you power and backs up your arguments for why it's important to focus on any disparities you identify, and it lets you measure how you're doing. And that moves into another reason it's important. Identifying your biggest gaps or areas you might take action for improvement helps you strategically allocate or identify resources needed. So looking at where disparities are or gaps are in your own data might help you understand where, for example, you need to hire or train new staff. And finally, one more example here in Minnesota, collecting and submitting a variety of data elements related to equity are needed for statewide reporting and healthcare homes requirements. So back to what data you might want. We just went over an example of healthcare and health disparities by race and ethnicity, but there are many other ways that you might look at health inequities. Here's a list that has just a few ideas, and you even might combine some of these possible data groups and look at more than one component at one time. So in the interest of time today, I'm not going to review these in detail, but just want you to be aware there are national standards for collecting some of the data that's outlined on the previous slides. Specifically in this case, those national standards are through the Office of Management and Budget, and then more specifically for some healthcare data collection through Health and Human Services Office of Minority Health Standards. But taking that example previously of standards for race, ethnicity, and language data to Minnesota, here's what clinics here collect and submit. So the Minnesota community measurement requirements for statewide data submission include patient-reported race and ethnicity, preferred language, country of origin, and insurance status when you submit those required measures, and you should have this data already in some form. There's also some other fields you collect and submit that might be helpful at looking at disparities, such as gender and zip code. And then finally, where might you get this data? So the obvious answer is your EHR. This is what you submit as a healthcare home. But consider what else you might pull in and either look at alongside that EHR data or to be able to link to it. MDH or other local public health data can be helpful. As we'll hear from Westside in a moment, patient survey data can be enormously helpful. And is there anything that you're already submitting that you might be able to repurpose or reuse rather than needing to start from scratch? And finally, partnerships might fall into any of those previous categories. And in general, is there anyone else that might be able to help you look at or pull data together? To close, there's just a handful of useful resources that might help you look at or use data to improve inequities in care. So the first here comes from the Office of Health IT at MDH, and it's a really practical guide to using EHR and disparity data in communities. The second link is the handbook for Minnesota Community Measurement that outlines your specifications for collecting and submitting this data, but it also includes some really helpful tips for how to look at and use it. The third is just a quick link to your data requirements under healthcare homes. And then finally, once you've identified some areas you might want to focus on, you could look at Culture Care Connection, which includes resources for providing culturally specific care to Minnesotans. So in sum, there's a lot of ways we can and should consider looking at slicing and dicing our data, but it's not enough to just collect and report it. We have a responsibility to use what we've learned to improve care and health for all the people we serve. So I'm excited to turn this over to Westside Community Health Services to share how they've looked at their own data and how they're using what they found, and how they identified some more data they needed to make a bigger impact for their patients. So Kathy, I'll turn it to you.
Thank you. Good morning or good afternoon to everybody. Glad to see people are on the call. I'm Kathy Colhane-Para.
And I'm Chris.
So the two of us are here and we're going to have some slides. Did you send me the controls for the slides? Or do you want to do that? Oh, that's right, I got to click on something. We practiced this already, but So a little background about us as Westside Community Health Services. We're a federally qualified healthcare center, which is also referred to as community health centers. We're the largest one in Minnesota. We've seen over 36,000 patients, and these patients have a lot of challenges. Almost 40% of our patients are uninsured, and the vast majority of our patients are non-English speaking as their primary language. Our two languages are Spanish and Hmong. And with that, we have a lot of people who would rank low on the health literacy scales. But what we're really thinking about our whole population is to what extent are they dealing with issues in their everyday lives that could be affecting their health? And oftentimes those factors are being lumped in together under the term of social determinants of health. What are the social economic factors that are affecting their health before they come to see us, as well as their access to see us, as well as their response to the issues we have and addressing them, and what things they can do for health care to improve their health, and particularly around issues of equity or inequity as we try to strive for equity. So the project we're going to talk to you has a couple of goals here, and that is we want to create a strategy to identify these social determinants of health factors that we could be affecting people's clinical care at Westside. And we want to evaluate then the connections between the social determinants of health and their clinical care, particularly around measures that we're already doing for MINCOM, but also as a federally qualified healthcare center, we have a set of elements we have to report to the federal government called UDS. Some of those are considered preventive and others are chronic diseases. And then once we've identified those connections, to try to identify, plan, and then implement practice changes in order to move towards health equity. So the problem here is that we don't have the data, right? As Stratus Health so nicely reviewed, yeah, we're doing RELO, race, ethnicity, language, country of origin, gender. We're also doing some housing because we have a public housing clinic and then we have homeless clinics. So we have some data on housing, but not for everybody. And we really haven't been asking about social determinants of health, about their insecurities around housing or food.
Hi, we're having trouble with our sound. We've lost our speaker. We're going to text Kathy real quick here and see what has happened with our sound quality. I can remind you that while we're waiting to reconnect to Kathy, that you're invited to submit questions through the chat function. And perhaps while we're waiting, I'll also just remind you of a couple of other things that are coming up that I was going to tell you at the end, but I'll just tell you now. So let's see, we've got, if you have been to the LNS lately, you will notice that we have a course out there on implicit bias in healthcare, an e-learning course. And the content of this webinar is kind of connected to that. So you might want to check out that course, also developed with Stratus Health. Also, just to let you know, we have a course coming up soon on quality improvement. This will be, again, an e-learning course, and there will be a corresponding webinar on December 6th. And then finally, we have I wanted to let you know about Learning Days. This is our annual learning conference that takes place every spring, and which this year will take place on April 9th and 10th at the Continuing Education and Conference Center, University of Minnesota St. Paul campus. We just this week issued the request for proposals for breakout sessions. So if you have information that you would like to share about your practice transformation journey, we would really love to have your proposal. They are due November 9th. So you'll need to visit the Healthcare Home website for more information. Okay, we've lost our other speakers, and I don't know if they even know that. I'm wondering if you feel comfortable taking us through some of these slides?
You know, I'm not terribly familiar with them. I can walk through them. There's a lot of detail that they would need to go into the weeds on. I can walk through them and outline a few of the different data presentations that they've shared.
Yeah, I'm just kind of at a loss about what to do. We can't reach them.
Yeah, I've tried sending them a note as well.
Okay, well, let's trust that they're going to try and get back. And in the meantime, if you wouldn't mind winging it, so that since we have people on the line.
I'll do my best. So,
all right, thank you.
I'm going to scan over these first pieces here because it gives some context on how Westside got to where they are. But outline is, I think, several people, I'm not sure how many, went through the Disparities Leadership Program through Harvard, and that spurred them to where they are today. And some of these details just go behind how that is outlined. The bulk of the data that Westside was going to share comes from this tool called their PREPARE tool, which is an acronym. I don't have the acronym handy, but it comes from the federally qualified health centers and community health centers nationally. And it's a tool intended to collect social determinant of health data. I think Westside adjusted a few of the questions just to specifically fit their patient population, but it's a patient-completed survey. It outlines the things you'll see here, so migrant work, veteran status, information on household size and details there, income and education, not specifics, it's multiple choice, so checkbox as to which best fits the respondent. Resource needs are on the PREPARE tool as well, so food challenges, needs in help paying utilities and child care, transportation needs, clothing, just basic human resources. Self-evaluation of social and emotional health, so stress, supports, access to care and paying for care. Safety, so physical, domestic concerns, emotional concerns, and then health literacy. And I think the social worker question was added by Westside. So the implementation, I'll walk through this. They'll need to go into some more detail here, but designed a workflow option was where they landed on of completing the form at the time of registration for the patient to collect this data and streamlining this into the EMR so the data can be pulled out of the EMR. We can share these slides afterwards, but here's their workflow. So patient arrives for the clinic appointment. The front desk staff screens and asks the patient to complete the form, which outlines those data elements I described previously. The patient completes that at some point and gives it to the medical assistant during rooming. At that point in time, it can be determined if any other resources are needed for that patient. If there are resources needed, the medical assistant alerts appropriate staff, so behavioral health staff or social worker for whatever interventions or needs would be helpful for the patient, and that data gets entered into the EMR. When the provider arrives, there's a brief review of the form to ensure if there's any other urgent needs that those are met at that time. And then I think the flag is added to the integrated consultant for future follow-up. Some future enhancements are noted below, so some more data analysis, implementation in different populations, and then adding some additional assessments of health literacy or family. And I think there's interest in integrating or aligning it with NowPow to refer out to social assistance. So some details on the PREPARE and what's been collected to date. The tool has been given to the adult population only at the largest clinical sites that Westside has. A little over 2,000 people to date have completed the forms. They're aligning these social determinant of health data with the quality of care measures that they're tracking on, and then analyzing the data to inform practices and interventions and things to change around preventative care, cancer screening, or chronic diseases. So here's some just data slides outlining the populations. So some details on age, gender, and race, ethnicity of patients analyzed to date for PREPARE. So age, you'll see most people are in the 29 to 38 age range. So under 70 is the bulk of the people that have completed this to date, and most are women. Race, ethnicity, data collected so far, most are white, Hispanic, and most are public insurance type. And this next few slides outline some of the select PREPARE questions. So some of the things I'd outlined on data elements collected. Social integration, I'll have to look into details on what this entails. Stress, self-evaluation of stress would be, does the patient have any stress, some stress, or a lot? Most assigned that they had some. The transportation question was transportation to get around to daily needs, so most do not, or reported that they do not. And most reported stable, excuse me, stable housing and high school education for overall. So overlaying this first slide here shows some of the typical social determinant of health or race, ethnicity type background questions that might be most easily accessible to you. So age, race, ethnicity, and insurance are shown here just to break out who is being screened for cervical cancer. These categories are something that federally qualified health centers submit and collect through the Uniform Data Set, the UDS. So you'll just see some basic demographic. You can look for gaps and areas to intervene here, or where you might want to improve. What this extra data that comes from Prepare shows is some other more specific, granular, disaggregated pieces that you could look at, and they're looking at for areas to intervene. So the same overall pieces in a few previous slides, social integration, stress, lack of transportation, and housing stability, might illustrate some areas more specific than just the race, age, ethnicity that were on the previous slides. Similar example for diabetes. These are the UDS screening categories for age, gender, race, ethnicity, insurance, and looking at where performance is in those various groups.
Laura, I think we have Chris back.
Oh, good. Hi, Chris.
Hi, can you hear us?
Yes,
we can hear you now.
Oh, wonderful. Okay, wonderful. Thank you.
We've been able to hear you for these last several slides, and we commend you. We think you've done a great job with our slides. If I could go back just a little bit, maybe to try to say, so on the on the cervical cancer screening, our overall rates have been about 60%, and we've had a difficult time kind of getting them lower than that. So we thought maybe by looking at these social determinants of health, that might give us a better idea. So if you go back up one even more, you're right, this is the data that most people are going to do with RELO, race, ethnicity, language, country of origin, right? And as you look at that, it's like it's our Latina women who seem to be doing the best. Then if you go to the next one to try to break that up here a little bit more, right, if looking at this new tool called the Prepare tool that's helping us identify social determinants of health, and looking at some of those, it seems like those who are more social isolation, so saying that they have less connection with important family members. And we think these are many Latinas who are here in this country who've left their children in their countries, right, or left their parents, and so they're feeling pulled between family here and family elsewhere. So they're not having as daily connections with people who are really important to them. So people with higher social disintegration, less social integration, are having lower rates. Those people who are pressing more stress are having lower rates. Issue a little bit with, transportation. But looking at the housing stability, it looked like our stable housing seems to have more needs in getting less cervical cancer screening than those without. Education doesn't seem to be a factor. Less high school education, actually, we're doing higher rates. And again, we think those are probably right to our Latinas. We think our strength historically has really been reaching out to the Spanish-speaking community with Spanish-speaking providers and place where people call home and are comfortable here, as well as the cultural orientation that Latina women have brought with them to say, yeah, I need my pap smear, that there's been a socialization process that people are bringing here that makes it a little bit easier for us. So kind of then with diabetes, for the UDS federally qualified measure we have to give, uncontrolled is greater than 9%. So this is our controlled, which is less than 9%. Our overall rate about that been about 75% control, meaning 25% about that has been greater than 9% A1C. Seeing that our elders are having actually better control than our youth, we're having a lot more younger folks than older folks. Excuse me, I take that back as an aggregate there. Race and ethnicity, it seems like everybody's kind of struggling insurance-wise. We're struggling all the way across. So then when we looked at our social determinant of health to try to, at the next slide, try to use this data to say, now are we identifying those people who are having harder times? So this again kind of inverted with controls. that social integration doesn't seem to be doing so much, but those without stress are having better control. So those with stress are having worse control. Those with transportation, the transportation seems to come in here with this one, whereas it didn't so much on the other in terms of having lack of transportation, having lower rates, because you have to, to get in, to get your medications, to get your follow-up, that maybe then you're having less control on your diabetes. Education and housing on this one didn't seem to make much of a difference. So we've just recently gotten this data, and I'm giving you some of our thoughts about how to put this together and who we're serving well and who we're not serving well. And the next challenges are great about how to understand the data, but then to address our practices. And Chris is going to talk a little bit more about what we're thinking about doing from here.
Yeah, absolutely. So, we know that we're really just at the beginning of this, and I'm sure Laura did a fantastic job of covering the Cotter model, but I just wanted to mention one thing because it really does involve our next steps, and the Disparities Leadership Program at Harvard really helped us to understand where we are at in our process for implementing this level of change in our organization. And one thing, and I think when we initially did an assessment of ourselves, we found that, we were pretty far along in the Cotter model, but then as we really dug deeper into our process, into our data, and into the cultures of our organization, we learned that we actually either whether we fell back or we had maybe done a little inaccurate assessment of our organization, we find that we're flipping all over the place on that Cotter model because our culture really is focusing on different elements depending on what level of change we are implementing. So I think as we really look to the next steps, we really have to try to move along both the operational strategies and our culture at the same time, and that's where some of the challenge does come in. So one of the things that we do want to do is expand our data collection. Initially, the Prepare tool was used at our 2 largest sites, plus our public housing site, which is a little bit smaller. But that covered the majority of our primary care, ambulatory care populations. But we really weren't able to focus on other special populations, such as our adolescent population being seen in our school-based clinics, our patients experiencing homelessness that were receiving care at our healthcare for the homeless clinics, as well as our pediatric population. The initial Prepare tool was initially validated for the adult populations, and now we are at the point where they do have validated tools also for pediatric populations, and so now we are at the level where we can start exploring some of these other populations and see how they might differ as we explore our data continually. The second one is to identify resources to respond to needs. So this data is wonderful, and one of the first questions that comes up with your mind of like, well, that's really good data, but what do we do about it? We know that maybe our non-Latino women are not as up to date with their pap smears, but how can we help them get up to date? And so that was some of the mental process that we're going through of how do we really change our practice when we look at this data, and how can we really target our different populations in different ways. One of the ways in which we are planning to implement change is in NowPow. I'm not sure if everybody has heard of NowPow, but it started in Chicago, and it basically is a resource that a lot of research was gone into to really explore what are all of those community resources that we want all of our patients to have access to. And they've created a very robust database for this. And so what we are going to do is actually implement the NowPow solution into our EMR, and so that when we have a patient that maybe is showing a limited resource in an area, a provider can then order a soft resource for that patient to go to and to receive additional resources. We are implementing this system in a way where it will be bidirectional, so the provider will also hear back on if the patient actually went to that resource. Again, not an advertisement for NowPow, but it's just another way for us to use extra resources. What we want to do then, though, is we want to bring in that NowPow data, that resource utilization, with our prepare data. And so we can say, okay, well, this population did have a lower completion of their pap smears, but when we sent them to this particular resource, that really improved that particular strategy. And so it really does, you know, open that door really wide to say, here are some additional strategies, and here's how we can monitor to make sure that we are progressing forward in the way that we want to. And then lastly, to evaluate the results to identify clinical interventions. And one, you know, I touched on this a little bit of, you know, you have all of this data and you recognize, yes, I have a disparity in this particular outcome, but what do I really do about it? And one thing that Westside is really focusing on doing is redesigning how we are implementing clinical care in our clinics so that if, you know, I guess one example, since Dr. Colleen-Pera touched on the diabetes question, is if you're a patient at Westside and you have diabetes, you may receive a number of different experiences based on who that provider is. But is there a way for us to really learn from our patient populations and have a very standard approach to say, well, if you're a diabetic here and you're coming in for care, you do have access to extra resources every time you come in, such as diabetes education and nutrition. So we're really trying to use this data to really come up with our clinical care design that best meets the needs of our patient populations, and also reduces some of the heavy burden that is on our providers and support staff. So Kathy, I don't know if you had anything else that you wanted to add on to any of those next steps, but those are three of the priorities that we're going to be focusing on next as we continue to explore this data.
Yeah, no, I think that does really well. Plus, looking at the time, people may have questions that can guide our reflections.
All right, so any questions for us?
Dorothy, have we had any come in through the chat function?
No, we have not.
All right. Well, I have a question for you, maybe to kick things off, and I'll remind the folks on the webinar that you can submit questions through the chat function, and we'll entertain them. We've got about 10 minutes left, but let me start us off. I'm curious about the NowPow and how that actually works for folks that are not familiar with it. So you've said that it's a robust database, and you're already implementing it with your EMR, which is wonderful. How might this work for folks who are in rural areas or affiliated with smaller clinics that integration might not be an option?
Yeah, so NowPow, you know, there are definitely different levels of implementation that you can do. It is an electronic database, so, you know, as long as you can log on to the internet, you can actually get into the NowPow database, and everybody can become a resource in NowPow so that you can receive referrals from others that may want to refer patients to you. So I think it's something definitely to think about, but it doesn't have to integrate with your EMR. That's just something we wanted to do to ease the burden for our providers. But it's just an online system. You can go in and, you know, basically refer a patient to a particular resource, and then they will receive that resource, and you know, you don't have to go with the system that allows you to receive that feedback back to you, but you can certainly use other methods for just coordinating with your community partners on whether or not those referrals were actually visited by those patient populations. You know, NowPow, you know, would be, if you haven't learned about it, they have a great demo, and they can give you the statistics of how many community partnerships that they have, but it's vast. It was pretty amazing to see the number of different resources that they had in their system, ones that we did not know about. So I think it is a useful tool for patients that are really struggling to self-manage their own health care because they have such limited resources.
So is NowPow a resource that's available to both patients and providers?
Yes.
And is there a cost to it, or is it free?
So there is a light version that is free, and then there is a larger version that is not free. So the light version allows you to be a resource. So, you know, Westside is both a provider and a community resource. So we could certainly be a resource and receive referrals from others in the system. I think if you want to send out referrals through the NowPow system, you would need to have at least one of the paid versions of it.
Okay, so people can just Google NowPow and probably come up with the rest of the information on their own, I would say.
Or at least request assistance, yep.
Have we had any questions, Dorothy?
We do. We have 2 questions. The first one, are there Minnesota users of NowPow?
Yes, absolutely. They're actually pretty widespread in Minnesota from what I understand, but they of course would be able to give you more of the statistics on that. I know that we are the first community health center to go with the paid version of it, but from what I understand, and as we kind of browse through the different people using it, it does seem to be pretty widespread.
Okay, the second question is, please describe the transportation resources being used.
So in the questionnaire, we're asking people about what transportation they have. And the adequacy of that. We didn't get into detail specifically if they've got their own car, or their neighbors are driving them, or their relatives are driving them, or they're taking the bus. As our major sites are on bus lines, and we're also located in public housing sites and in homeless sites, so that there are ways to try to help people who don't have those resources to be able to access us. But I think, you know, we have to talk to the Met Council. How come they have fewer lines at higher cost? It's driving everybody to having to say you have to have a car in this society today, and that's influencing health, and it's influencing health care. But you want me to be on my soapbox, or?
Any more, Dorothy?
Well, Laura would like to know more about the Cotter model.
Yeah, that's a good. Can you put it back on this?
Yeah, let's see if we can just get it back to the slide here. I'm having trouble getting back to that screen. I don't know if.
Oh, sorry.
Yeah, I'll let you do
Dorothy
it.
can take you back. We'll get that going here.
So while you're looking for it, I can say it's a conceptual model that Chris, as COO, have found a lot more helpful than I as a family physician.
There you go.
So, you know, what information you use and how things help you. But this is something that was helpful to Chris to conceive of the things we're doing. Okay. Back
so
down.
yeah, you want to go back to that model, that would be great.
So forward one.
Okay.
So this is a model, and it actually starts at the top of create a sense of urgency. And there, you know, and if you all want to Google the Cotter model as well, you're going to get a lot more information on it. But this is a stepping process. This isn't, so, you know, number 1 is create a sense of urgency. Number 2 is build or a guiding coalition. This is actually a work cycle. So it's not just something that, you know, which of these do I have, but you are actually working your way around the circle, and you're certainly implementing a new change and implementing a lot of culture change in your organization. So you might say that, well, I have created a sense of urgency, and now I'm to the point of where I want to enlist a volunteer army. So what we found out, just if I can share our own learnings from it, we thought we were at the generate short-term wins. We thought we had created a sense of urgency, we had a coalition, we had a strategic vision, we had the Army, and we had removed a lot of our barriers. So we thought we were somewhere between enable and generate. And as we really dug into our process, I actually felt like we had to take our organization back to number 1. because there are parts of our organization that felt that they had created a sense of urgency, and there were others that were totally oblivious to what we were doing around health equity or why it was even important. So I do think that this is a tool that can help you really understand where you are at, and you may find that even though you might initially assess that you're further along, when you think about complete organizational saturation, I think most people find that they have to take a few steps back, and they really have to collect all of those corners of the organization that maybe didn't come along the first ride, and you need to collect them so they can come along with you as you work through this different change implementation. But as Kathy said, it is a conceptual model. It's just one tool that you can use to really assess where am I at with this, and are we really moving ahead in both our culture and our process? They really both have to be looked at, and to move ahead in one without the other isn't going to get you too far.
And I think if you go back to your CQI model, the only step here between institute change and creating sense of urgency is that, kind of grab your data, evaluate where you're going. But it's consistent with CQI, right? It's an ongoing process.
Absolutely.
But it's got a lot more different types of steps than you don't necessarily have in in terms of how do I do this?
Well, and it's a cycle.
Yeah.
It is a cycle, and it's one that you need to continually go around the cycle. Many of you have heard of the PDSA, or Plan, Do, Study, Act cycle of quality improvement, and it's very much the same way. And you might find that, you can spend a lot of time planning, but then by the time you get to acting, you do have to kind of go back to that planning stage, because we need to plan a little bit differently. So I think it's just another way to really look at how you're implementing change in the organization, especially a formal change like health equity and disparity change. Mm-hmm. It's a big leap for many organizations, and we really do need to really do some organizational assessment to make sure that we're moving ahead in a way that is really lending a high level of integrity to our work.
What's the one before that? Okay, with that, we're going to have to close it up. I want to invite you, if you have further questions for any of our presenters, to contact them at the information on the last slide. And these slides will be posted on the Healthcare Homes website before too long. To receive a certificate of attendance for today's webinar, please complete the evaluation that will be emailed to you following this webinar. And I'd like to once again thank Laura, Chris, and Kathy for your help today. And also, I believe that Westside will be presenting at many faces if you'd like to learn more about this information. All right, and I'd like to thank the people on the line, and once again apologize for the breakdown in the middle, and I hope that that didn't discourage you too much. Come back, we'll have another webinar on December 6th, and thank you for being here, and enjoy the rest of your day.